Good evening, Dr. Ramesh.
Good evening, sir.
So I think we can start in a couple of minutes. There are some people who are still joining.
Yes, sir. We can wait for another couple of minutes, sir.
Uh, Good evening, Dr. Ramesh. I think we can start. Quite a few persons have joined.
So I think we can start, and a few may be joining in a couple of minutes. So we can start with the introduction, sir.
So Dr. Ramesh is the faculty for today, and he is Dr. Ramesh Aggarwal. He is the professor of medicine at Lady Hardinge Medical College and a very sought after teacher and a PG supervisor. Also, number of publications he has. He is also a governing body member of a Delhi State chapter and secretary of Delhi Diabetic Forum. And right now, he is also having a position in the Ministry of Assistant DG, also Health Services. So, Dr. Ramesh, I welcome you and thank you for consenting to take today's class. So, over to you for the today's session, which is a very common and pertinent topic. Dr. Ramesh Agarwal, sir.
Thank you, sir. Thank you for your kind introduction. At the outset, I would like to thank Dr. Kamlesh Tiwari, sir, Dr. Anupam Prakash, sir, ICP under the aegis of API for giving me this opportunity to speak and interact with the postgraduates and the junior residents who have joined this afternoon, taken and spared their time to listen to me. The topic is, as sir you said, is very relevant, very common, and sometimes we don't know whether to give the importance to an enlarged liver or whether to ignore the enlarged liver. It sometimes becomes a problem, especially in a patient who comes to us with, say, some non-specific symptoms, and on an ultrasound he gets a liver enlargement, and then what to do, or even to think of that. So this is a common scenario, but of course, enlargement of the liver in certain situations do help us in reaching a diagnosis, and so that becomes important as a part of our clinical examination. So let me share the screen and we can begin with this. So I hope my this screen is visible to you and I'm audible also. In case it is not, then you may please either speak or share in the chat. So, hepatomegaly. So, I will like to begin with some clinical scenarios which are very common and in day-to-day practice, which we see. You can just go through these scenarios, and then probably we can discuss at the end of this lecture that how commonly these all these clinical scenarios, myself and you people all see these patients. So, let us see this patient who is a 30 years old man, and he comes with fever and jaundice and some right upper quadrant pain for the last 10 days. So I think this is also a common scenario, that someone coming with to you with acute febrile illness with some jaundice and upper quadrant pain, and he has got a tender hepatomegaly and of course icterus and a mild splenomegaly. So must be some infective etiology which is going on in this patient, as the history is very short. So if you can think of something, you can post in the chat, uh, and then we can always have the discussion on what was your diagnosis. You can just write as case scenario one, and you can put in your differential, your diagnosis or the differential diagnosis. We will come to this scenario again at the end of the lecture. So one scenario is that a simple patient coming to you with acute febrile illness, jaundice, having some pain in the abdomen. You examine patient as tender hepatomegaly. Another patient is there who is an elderly male who has got a progressive weight loss, has got a now jaundice is there, is a painless jaundice, and the abdominal distension is there for the last 2 months. Patient didn't take any alcohol. On examination, you found that the liver is enlarged. It is hard nodular hepatomegaly. There is ascites and cachexia. So seems to be quite a likely diagnosis. What I think is relevant, and you also must be thinking on the same lines. But then you again, as a case scenario two, you can put that your differentials in the chat box, so we can look at this scenario at the end of the lecture. So one was a tender hepatomegaly, one is a non-tender but a maybe a hard and a large hepatomegaly in an elderly male. Another patient comes to you, again a middle-aged man, is a diabetic. Now he has fever and a right upper quadrant pain for 5 days, but there is no jaundice in this patient. And he's again, he also has a tender hepatomegaly and he has fever also. So something similar to the case one which we just displayed. So what is your differential diagnosis? You can put it as case scenario three. Another scenario is if in the day-to-day practices that someone comes to you with a, this is quite a common scenario, 50-year-old male who is a chronic alcoholic, and he has jaundice and anasarca with ascites, and it's difficult to find palpate the liver, but yes, when you examine, he has got a firm and a non-tender hepatomegaly, some spider angiomas, and a mild ascites. So diagnosis seems to be quite likely. So what I am thinking, you must be thinking the same way. So you can put your differentials in the case scenario 4. Again, there is one man who has got a painless progressive abdominal distension, and he doesn't have any history of fever or any alcohol intake. Simply examining the patient, you found that he's got a huge liver and a huge spleen. So massive hepatosplenomegaly with some pallor and lymphadenopathy. So I think such type of patients also you must have seen. So 5 or 6 scenarios are there. Someone having a painful hepatomegaly with fever, someone having a painless hepatomegaly, someone having a painless massive hepatosplenomegaly. Then look at this patient who is again a middle-aged gentleman with a history of obesity, diabetes, hypertension, and he has got a sedentary this lifestyle. And when you see his or her ultrasound, then you found that there is a ecogenicity of fatty liver. This is a very common scenario. You must all be having these patients coming to the OPD. Doctor Sahab, someone has told me that my liver is fatty, what to do? So again, this is also a common scenario which you can keep in mind. Then many more scenarios are there which may not be reflected in these 5 or 6 scenarios. I have tried to give you an overview of how the patients come to you with hepatomegaly, and then let us discuss how to go about all these cases. So just a brief introduction about the hepatomegaly, that liver is enlarged, that we all know, it's simply hepatomegaly. Then hepatomegaly may indicate some systemic or an hepatic disease. And the let us go system wise on the anatomy of the liver. The liver, as we all know, has got two lobes, the right and the left lobe. The vascular supply is by hepatic artery. There is another supply which is by the portal vein, and there are hepatic veins. Lymphatics and nerve supplies are also there by the celiac or the hepatic nodes. Autonomic innervation is there. Sometimes they are more relevant for the surgeons. For the medicine point of view, identifying the lobes of the liver with the supply of blood supply is relevant. Liver has got many metabolic functions, including protein synthesis. It regulates carbohydrates, fats, proteins, and that's the problem when, as it is a glycogen storage organ, so it may suffer from over nutrition, maybe because of fats or carbohydrates. It has got a role to excrete bile. So when the problem comes with excretion, so it also suffers. Detoxification is one of the main mechanisms of the liver, and it breaks down toxin drugs. It helps in the immunity. Kupffer cells are important for all postgraduates. You must be knowing about it. They are responsible for maintaining the normal ecogenicity of the liver. So let us come to the causes of hepatomegaly, in which circumstances liver can be enlarged. So as we all have been taught that the causes can be divided into infectious, metabolic, infiltrative, vascular, neoplastic, and some miscellaneous where the drug or the alcohol may be the culprit. I've tried to give you initially all 5 or 6 examples which covered these causes. So let us go one by one to these infectious causes. First of all, the infectious causes. Very common in our setup, viral hepatitis. Of course, A and E are mild hepatitis, self-resolving, but the problem is with B and C. So these patients may come to us with some liver enlargement and may or may not be jaundice. A clinical scenario was discussed where the patient came to you with some fever and tenderness in the abdomen. So those patients generally have liver abscess. Now, liver abscess can be pyogenic or it may be amoebic. Generally, these two categories are there, what we see. And of course, tubercular liver abscess is also there. But in those patients, we do have systemic signs of tuberculosis. Maybe some pulmonary or some abdominal, some ascites may be there. Or sometimes patient may not have those signs of tuberculosis, but the abscess, when you drain it out or you send the liver abscess for investigation, you may find the AFB present in it. So viral hepatitis, liver abscess, parasitic infections, they are also not uncommon, like echinococcosis. Some bacterial infections responsible for this hepatomegaly is leptospirosis, brucellosis, and tuberculosis. Tuberculosis may present with liver abscess, or tuberculosis may involve the liver even without causing liver abscess. So there may be many unknown uh, unknown responses of how the body behaves with the tuberculosis. Leptospirosis, we all know, is one of the diseases which, if not treated timely, can be fatal enough. Patients will have severe jaundice presenting with acute renal failure, fever, acute presentations. So broadly, these are the causes of infectious etiology: viral, bacterial, parasitic, and some liver abscesses in the form of pyogenic and amoebic. Then as the liver has got many storage functions also, one of the common problems which these days we are facing is with the non-alcoholic fatty liver disease, maybe because of diabetes, obesity, lifestyle disorders. Then some rare disorders like glycogen storage diseases, hemochromatosis responsible for hepatomegaly, Wilson's disease where copper is accumulated, and alpha-1 antitrypsin deficiency. They may not be very common in clinical practice, but it is always important to remember it as metabolic and storage disorders. Then there are infiltrative and granulomatous diseases, sarcoidosis, amyloidosis, lymphomas, and leukemias. Generally, these patients have some representation or some of their effects in the either in the blood or some other organs, and liver may be secondarily involved. So we can get a clue from the other systemic manifestations of these diseases. But yes, of course, liver can be involved and it can be enlarged in these granulomatous and infiltrative disorders. Some things like congestive hepatomegaly again is one of the very common presentation which you all people must have seen, that the patient is having symptoms of right heart failure and a congestive liver, where you put your hand on the right upper quadrant and the patient winces with pain and a background of heart failure. Then Budd-Chiari syndrome is also not very uncommon these days. You have many patients who come to you with hepatic vein thrombosis, and it may be an acute Budd-Chiari or a chronic Budd-Chiari where the liver may be enlarged. Portal hypertension as a complication of chronic liver disease is a very common cause of hepatomegaly and other complications. Veno-occlusive disease again can cause liver enlargement. Not very common, but yes, from a gastroenterologist point of view, it still remains an important entity. Now, neoplastic causes should never be ignored, especially in elderly patients who come to us with, say, asymptomatic jaundice presenting with some huge livers, and where the nodularity of the liver can be felt, where the margins of the liver is sharp and the surface becomes hard. So there are many, either it can be a primary liver tumor or a secondary liver tumor. So that one etiology should always be kept in a patient who comes to us with, say, anorexia, weight loss, sometimes raised ALP in the investigations, thin patient without any history of any drugs or toxins. Autoimmune diseases are very common these days. Autoimmune hepatitis is not very uncommon, may be kept as one of the possibilities for hepatomegaly. Then some surgical emergencies like primary biliary cholangitis, sclerotic cholangitis are also one of the common causes for liver diseases, liver hepatomegaly. Alcohol, very common cause of chronic liver disease, causing hepatomegaly. Drug induced, some of the drugs like methotrexate, imidazole, steroids, and many other can cause hepatomegaly. Poisoning by some mushrooms or heavy metals can lead to hepatomegaly. In the miscellaneous causes, acute fatty liver of pregnancy, sometimes in acromegaly, thyrotoxicosis, polycystic liver disease, they all can be responsible for hepatomegaly. So the question is how to approach hepatomegaly. Of course, hepatomegaly is just, say, a sign of a disease. As such, it is very unlikely that liver per se is responsible for anything. But yes, it may be secondarily involved, or sometimes it may be primarily involved by malignancies. Then it becomes a source of hepatomegaly itself. Otherwise, if we go by the history and a good examination, so we generally can attribute the cause of hepatomegaly to that particular etiology. So history, examination, pattern of involvement, whether it is an isolated hepatomegaly or it is associated with splenomegaly, that do help. And the investigations and the workup comes later on. So as a good clinician, my advice to all the residents and all the colleagues who are on this platform is to have a good history and examination. Try to frame your own diagnosis of the hepatomegaly. The clinical artist hasn't died yet. It still remains live, and we should uh, just rely on the investigations to confirm our clinical diagnosis. So very common thing, asymptomatic hepatomegaly, someone may have hepatomegaly, it may not have any reason. So we can just leave it like that. We can follow it yearly. Generally, patient may have some pain in the right upper quadrant. Patient will go to get an ultrasound and you may find hepatomegaly. Patient may have some dull aching pain. As we discussed, it could be because of the liver congestion, because of the right heart failure or the Budd-Chiari syndrome. Sometimes just if you put a hand on the patient's abdomen, he will wince with the pain, liver abscesses, infections, That may be the underlying problem. And slow progressive pain may indicate malignancy. So pain is one of the important features. Painless or painful hepatomegaly helps you in making your differentials narrow. Similarly, jaundice, that means liver is involved. Reasons may be any of these, may be pre-hepatic or hepatic or post-hepatic. So this has been wisely covered by Dr. Anupam sir in his first class, how to approach a case of jaundice. Then patients may come to you with some fever and chills, as I discussed in one of the first cases. So the etiology can be infections, viral liver abscess, malaria. Again, one of the important differentials of hepatomegaly with fever and jaundice. Patient may have systemic symptoms like weight loss or fatigue, where the problem may be due to chronic liver disease or malignancies. Again, anorexia, nausea, vomiting can be there in any of the liver disease. Pruritus particularly will help you in limiting your differentials to primary biliary cholangitis or sclerosing cholangitis. Sometimes history of night sweats, as the old time teaching says, may help you in deciding whether it is certainly tuberculosis or lymphomas. So as I told you, systemic symptoms do help us in localizing the etiology for hepatomegaly. So some important history like travel history. Now these days, travel is quite common. So someone from a malaria or leptospirosis endemic zones have recently traveled to the other places. So clinicians must be aware of and must take the history of travel. Exposure to animals is not very uncommon. Rat bite leading to leptospirosis, brucellosis in patients who are working in the cows or the milk, where they may come in contact with those animals which are having brucellosis. So this is the traditional teaching that we must have a good history, including exposure to animals, travel history, any chemical exposures, and some relevant family history. Sometimes the liver disease may be traveling in the families like Wilson's, hemochromatosis, or maybe some storage disorder. So a good family history should also be taken along with whenever we are discussing, trying to find a case cause for hepatomegaly. Cardiovascular history like right heart failure symptoms or signs, but carry and any history of hypertension or diabetes that may tell you that probably metabolic syndrome may be responsible for non-alcoholic fatty liver disease. Changes in the stool color, urine color. As I mentioned in the first lecture, it was told to you what is the importance of clay colored stools, what is the importance of dark urine. So that will help you in deciding whether it's a pre-hepatic, hepatic, or a post-hepatic jaundice. History of upper GI bleed like hematemesis, melena will tell you yes, the reason is likely to be chronic liver disease and portal hypertension. Malabsorption syndromes will present to you with diarrhea, steatorrhea. Again, a history of uh, say a fat or the stool sticking in the pants will give you history of steatorrhea, and you may have a clue that yes, this patient is suffering from malabsorption syndromes. History of viral hepatitis A and E, you can always take a history of any foodborne infections. For B or C, you have to take the history of any IV drug abuses or sexual problems. Blood transfusion history for viral hepatitis, any past history of tuberculosis. As we mentioned, hepatic tuberculosis can present in different forms, maybe in the form of liver abscess or enlargement of the liver or just simply involvement of the liver. It can also present with peritonitis, intestinal tuberculosis, and so on. Any history of known malignancies, any primary malignancy somewhere, and that has metastasized to the liver. So that is also to be taken care. Some yes, this we have discussed that obesity, diabetes. This is a very common problem these days, and patients are presenting to you with NAFLD, and if it is associated with raised ALT and AST, then we label the patient as NASH, and these patients may ultimately go into fibrosis and cirrhosis if not timely intervention is done in for these patients. It's better to get an ultrasound and a fibroscan for these patients and give them good dietary advice. Examination of the KF rings for Wilson's, for hypogonadism, skin hyperpigmentation, for hemochromatosis. So that can also give you a clue whether the etiology is related to endocrine or metabolic. For inspection, it is important to, uh, first of all, as we say, that whether the abdomen is distended or not, there are prominent veins or not, any signs of puncture in the skin of the abdomen, porocytic fluid, any obvious hernias in the umbilical or any other areas in the abdomen. Good general physical examination, which should include to note for the icterus, to note for the pedal edema, to note for the peripheral signs of chronic liver diseases like parotid swelling, alopecia, Dupuytren's contracture, or palmar arrhythmia, or flaps. So this is all you what you know. But a good general physical examination followed by an inspection, palpation for the liver should be done in the form of you should be able to describe the liver, how much it is enlarged, what is the span of the liver, whether liver is tender or non-tender, what is the consistency of the liver, it is soft or hard, what is the edge of the liver, it's a smooth margin or irregular margin. So these all will give you a clue whether what could be the possible reason for hepatomegaly. And then you can listen for the bruit in case of there is some tumor or a venous hum in case of portal hypertension. And look for the free fluid by shifting dullness. So good clinical examination will definitely tell you whether the problem is local in the abdomen itself, in the liver itself, or it's a systemic problem. So as I mentioned, painful hepatomegaly can have reasons like hepatitis, liver abscesses in patients of congestive heart failure. Painless hepatomegaly can be present in malignancy, fatty liver, storage disorders. Patients with fever with hepatomegaly, they can be in viral hepatitis, in abscesses, lymphomas, tuberculosis. Patients who have jaundice and hepatomegaly, it can be present in hepatitis, cirrhosis, cholestatic liver diseases. Weight loss means either cirrhosis, some chronic infection, or malignancy. Alcoholic liver disease with a history of alcohol abuse, and congestive hepatopathy, as already mentioned in point one, with the right heart failure symptoms. So this is one of the way in which we can delineate various causes of hepatomegaly. And on bedside, this is important also. In a short span of time, we can just rapidly screen the patient for any of these positive histories and narrow our differential diagnosis. Investigations have, of course, they will help you in deciding the primary etiology of the hepatomegaly. The basic investigations are the liver function test, where ALT, AST may be raised, ALP suggestive of some obstructive lesions. Viral markers can be done, and imaging involves ultrasound, CT, MRI, a fibroscan, and sometimes we need a special investigation for the liver, including liver biopsy and elastography. So, coming to the clinical scenario, number one, where we have a patient who is 30 years old male who presents with fever, jaundice, and right upper quadrant pain for 10 days. So he has a history of eating street food frequently. On examination, he has tender hepatomegaly, icterus, and mild splenomegaly. So let me see the chat box first, if you people have responded something. Mm, yes, someone has responded with this, that case scenario is acute hepatitis, case scenario 2 is nodular liver cancer, viral hepatitis, and HCC. Okay, again the same thing. Enteric fever, tropical fever, liver mets, acute viral hepatitis, case 4 CLD, case 2 is carcinoma of the head of the pancreas with mets to the liver, CLD. Yes, so many of you have responded, I think, quite nicely and in a right way. So in this patient, if we see that he's a young man who has got a history of fever, jaundice in the right upper quadrant, pain, and he has got a tender hepatomegaly. So of course, someone who is having a short history can have a acute viral hepatitis. Closest differential in this case could be a liver abscess also. Liver abscess patients may or may not present to you with jaundice. They simply may have only fever and tender hepatomegaly. Jaundice here is pointing more towards an acute viral hepatitis. Patients of chronic viral hepatitis generally they do not have jaundice, and sometimes we may not be able to pick them with our routine examination. So acute viral hepatitis can be, as we already learned, that it may be because of hepatitis A, B, or hepatitis E viruses. And investigations, of course, can be with the liver function test, as we mentioned. Viral markers, which are available is for hepatitis A, hepatitis B, hepatitis E. Hepatitis C, again, it can be an acute presentation of a chronic liver disease, but in this case, there is no such history. So we can keep it lower down, both the hepatitis B and C. But yes, sometimes they can be just subtle uh, chronic liver disease, which are precipitated by some of or any of the causes. And basic ultrasound abdomen will help us in just ruling out many other things. It will certainly not be very helpful in deciding. And the treatment in this patient will be supportive in the form of hydration. And we should always avoid hepatotoxic drugs. And I hope you all people understand that avoiding NSAIDs and avoiding drugs which are hepatotoxic should be the priority, and maybe supplement with some glucose and these things. Patients of chronic liver disease, we must ensure that these patients do not suffer constipation or hypotension, also hypokalemia, otherwise their encephalopathy will be precipitated. So most of you people have tried to attempt it quite nicely and in a right way. So let us come to the problem number 2. So this was a 65-year-old male who has come to us with progressive weight loss and some painless jaundice and abdominal distension for 2 months. Now, again, you see in this patient, as we mentioned in the previous slides, the primary complaint of this patient is weight loss. Acute presentations, acute problems of the body do not present with weight loss. Weight loss means that this patient has a history which is something for quite long. Elderly patient, painless jaundice. Now, abdominal distension could be because of anything. It could be because of ascites, it could be because of hepatomegaly, it could be because of splenomegaly, or it may be just simply because of the constipation, which may or may not be there. And these problems have been there for the last 2 months. And importantly, this patient is not an alcohol user. And he has got a hard nodular hepatomegaly. And in this patient, he has ascites also and cachexia also. So diagnosis seems to be quite reasonable that there is an underlying malignancy. Now, malignancy, it could be a primary hepatocellular carcinoma, or it may be certainly, as you people have said, that it could be a metastasis also. So, any patient who comes to us with these symptoms should never be ignored. This is the lesson from or message from this particular slide, and thoroughly investigated. Whatever investigations are available and the patient is affordable, basic CT scan, some carcinoma markers, and then, if possible, an ultrasound guided biopsy will help in defining the treatment for this patient. And this patient will, of course, require surgery and multi-speciality. Coming to the third scenario, which is where the patient is a 40-year-old male and he has got diabetes and he's got a high grade fever, chills, and right upper quadrant pain for 5 days and no jaundice. Yeah, this is what I was saying, that you people also must have seen that patients of liver abscesses, they may or may not come with jaundice. Presence of jaundice will certainly points towards an acute viral hepatitis. Absence of jaundice, sometimes acute viral hepatitis may not present, but then you should have a strong suspicion of liver abscess. So the liver abscesses should not be missed, and because they are very common these days. And when we examine this patient, there is a tender hepatomegaly, and even in the X-ray, if you can appreciate, there will the right dome of the diaphragm will be raised. You all can just have a look on the patients who are coming with the diagnosis of liver abscesses. Their right dome of the diaphragm is raised as compared to the left, which is more than. Generally, it is limited to 2.5 centimeter, but in these patients, because of the liver enlargement, the do and the liver abscess, the right dome of the diaphragm is raised. So but the problem here comes is that whether this is a amoebic liver abscess or a pyogenic liver abscess. Now, depending on the symptoms of the patients, we sometimes try to conclude that this is a pyogenic or an amoebic liver abscess, but certainly it is very difficult without investigations. Even with the investigations, what can be inferred is that this is not an amoebic, but whether it is because you're not able to grow anything from the pus from the liver abscess. If it is even amoebic liver abscess, then you have to grate the walls of the abscess to get something out of that liver abscess, to have that to know the organism. Otherwise, very difficult to find the cause of the liver abscess. So it could be amoebic and pyogenic. The treatment is a cocktail of an antibiotic and a metronidazole, which will take care of the amoebic. The question is whether to aspirate that liver abscess or not in these patients. The one thing which we must remember is that the aspiration of the liver abscess depends on two or three factors. One is the clinical condition of the patient. If the patient is sick, if the patient is running fever, has got a raised TLC, and despite your treatment for a few days, patient is not responding, then it's better to drain out that abscess. Then patients who have liver abscesses in the left lobe of the liver, so those should be drained because they have always the chance to rupture, and the organ which can be affected by the rupture of the abscess in the left lobe is the nearby pericardium. The size of the liver abscess, the traditionally it was said that it is more than 10 centimeters should always be drained, but I think this is again a gray area where uh, the clinical decision will matter for aspirating the liver abscesses. But if liver abscess is early diagnosis and early treatment, better recovery. Another thing which we must remember is the duration of the metronidazole. Try to limit the dose of the duration of the metronidazole to say 10 days to 14 days. If you intend to give it more than that, then be prepared for the complications like neuropathy, which is not an uncommon manifestation of this drug. So coming to the next scenario, which is a 50-year-old male, and he drinks a lot of alcohol, and he has got fatigue and swelling of the legs and mild jaundice. And examination, there is firm non-tender hepatomegaly with spider angiomas and mild ascites. This is again a very common scenario in our wherever you and we people work. That patient will come to you with huge ascites and liver, and maybe from the postgraduate point of view and from the residents who all are listening, peripheral signs of liver disease, chronic liver disease, should be known to everyone. Another thing is that rapid drainage, say more than 1 liter or something like this, of the ascitic fluid, may precipitate hepatic encephalopathy. So that should always be taken care. Otherwise, these patients do generally, uh, they may have some complications, but they go to their home happily if we treat them nicely. Because we all know cirrhosis is an irreversible disease of the liver. It's the only treatment available is liver transplantation, which may not be affordable. But to these patients, we can always provide a better quality of life by, say, vigilant and senseful treatment. So this was a common scenario, and I think most of you must have answered it rightly. Alcoholic liver disease, cirrhosis, and the first thing which we should not forget is to always counsel the patient to stop alcohol, stop tobacco. We should take care of the nutrition. Diuretics for ascites will again remain one thing where we should have a judicious decision depending on the peripheral edema or only ascites, or whether the patient has got both ascites and edema. Furosemide, spironolactone, these other traditional drugs which we use, and the doses of this drug is well known to you. But again, rapidly correction of anything like ascites or edema will precipitate hepatic encephalopathy. So again, we must be very careful. Another thing which is important in these patients is the hematomesis and the melena, which may be apparent, which may not be overt. Dr. Shivalakshmi in her last class very well discussed about hematomesis and melena and the approach to the esophageal varices and all that related to very nicely. And these things we must understand when we deal with these patients. So I think the fifth scenario is again a painless progressive abdominal distension. Also not a very uncommon disease where you just have a patient who do not say anything. He doesn't have any fever, alcohol, or any other issues apart from anorexia, apart from some weight loss, age, maybe any, generally young to middle age, coming to us with hepatosplenomegaly, pallor, and lymphadenopathy. So massive splenomegaly, I think you must be aware, and if not, you must read. There are 8 to 10 causes of a massive splenomegaly. We must know them, remember them. And these patients will have a massive hepatosplenomegaly, liver will be huge, spleen will be huge, and the diagnosis can be confirmed by bone marrow aspirations, peripheral smears, and cytogenetics. The treatment of these patients will be by chemotherapy and imatinib for CML, and whatever the disease may be, the treatment is available, but the diagnosis, primary diagnosis remains in the hand of clinician, timely and primary diagnosis. This was what I was talking of, that a common scenario when someone comes to in your OPD totally asymptomatic, but because of some abdominal problem, maybe gastritis or something, got an ultrasound and found that the liver is enlarged. Now his question is whether to do something for the liver or not to do for this hepatomegaly. So again, it becomes very difficult at some times that at what stage you need to initiate any treatment. But as far as this non-alcoholic fatty liver disease is concerned, which has got a new terminology as MASH, which was also discussed in the previous lecture, the gold standard treatment still remains the weight loss, because it is a disease of a metabolic origin, where things like obesity, things like diabetes, dyslipidemia, they, our own dietary habits, our sedentary lifestyle, because there is no history of alcohol consumption in these patients. So this has been responsible for causing NASH. And so because it is a disease which has come by our own habits, so if we leave our own habits, if we improve, if we counsel the patient nicely, and if the patient reduces weight, have a strict dietary pattern, so this disease, till it reaches a stage of fibrosis, is reversible. So it's one of the very fortunate liver disease that this is reversible if timely intervention is done before the fibrosis sets in. The investigation for this is an ultrasound, and then if there is increased liver echogenicity, then we suggest for a fibroscan for these patients. Although the new drug has come for the treatment, vitamin E has always been there to supplement, but still the gold standard for this remains as the dietary and the lifestyle measures. So I would like to end my talk over here. It was something about how to do a systematic approach to the liver disease by a good history taking, by realizing which symptoms are there, which are particularly important. Importance of the examination of the liver and the systemic examination. Of course, with the general physical examination, investigations will always be there to supplement us. Some red flag signs like hematomesis, melena, weight loss, or some purpuras. So they need to be particularly seen in these patients. So with this, I will like to end my talk over here. I will stop sharing my screen and
Well,
uh,
thank you, Dr. Ramesh. I think it has been a wonderful
yeah.
lecture. Do we have any queries from the
Yeah.
audience? There is one protein intake in CLD patients. Are any specific quantity of protein powder to be taken? Number two, acute liver injury in malaria or leptospira. Is there any role of N-acetylcysteine? What are the main supportive measures to be taken, sir?
I
Number
think
three, any
regarding,
specific
yeah,
pattern? We can go one by one. Yes.
yes, sir. So I think protein intake in CLD patients is that we do not advise them to take some excess of proteins. And if the patient has symptoms of uremia which are setting in, then it's better to avoid any proteins like egg or excess of proteins. Minimal in the dietary supplement are always not advisable, but the in a routine diet what they are taking they can take, but that will again depend on the patient to patient. Uh, Not strictly protein powder is certainly not recommended in any chronic liver disease. That's my opinion. Uh, Acute, sir, anything to say about this protein powder, sir? Any of your,
Nutritional supplements in the form of protein powder, you are right, Dr. Ramesh. We should not advocate that. Basically, in
yes,
acute hepatitis, we advocate for high carbohydrate layer diet. And in chronic liver disease also, there are supplements I understand which actually have protein. But that is for patients of chronic liver disease with cachexic states. Dr. Ramesh is right. You have to have a very fine balance because these are the chronic liver disease patients who have a tendency to go into hepatic encephalopathy where ammonia levels are surging up. So you have to have a very careful balance and you should not give extra protein to these patients. So you will have to have a balance whether if the patient is having a wasting syndrome secondary to chronic liver disease, then definitely you will require to give some amount of protein, but then balance has to be made. So no prescription of over the board, I would say protein powders. I agree with Dr. Ramesh.
yeah. So the next question which here is that acute liver injury in malaria or leptospira, is there any role of N-acetylcysteine? What are the main supportive measures to be taken? I think a very nice question. The first question is very nice that yes, there is an acute injury in can be there in both malaria and leptospira or other any infection. Liver is one thing which is generally affected, and if you take timely treatment in just simply in the form of IV fluids, nutrition, so both of the injuries are reversible. Of course, I'm not talking about the antibiotics. If it is leptospira, you have to give antibiotic. If it is malaria, you have to give antimalarial. But for the liver, if you do a timely intervention in the form of hydration and simple nutrition, the liver injury will be reversed. And acetylcysteine, I don't have any experience in liver injuries in giving N-acetylcysteine in malaria or leptospira. Any of my colleagues, if have any, they may share.
Well, N-acetylcysteine is recommended only for toxic hepatitis, where there is a lot of necrosis, not for infective. Most of the infective hepatitis, this is a bystander phenomenon and it is usually reversible once you control the infections. It is toxins where you actually require N-acetylcysteine, especially for paracetamol, for which it is a known and recognized antidote.
Yes, sir. So that is our experience, and I think that seems logical also. Any specific pattern of liver enzyme elevation in congestive hepatomegaly? I don't think so. There is any specific pattern of liver enzyme elevation. In alcoholic hepatitis, we do have a reversal of the ALT, AST, but in common liver injuries, I think both ALT and AST rise. Yes, if ALP also rise amongst them, then we look it at a little suspicious way that there may be some sort of an obstruction, which may be a biliary obstruction, which may or may not be significant, but then it will depend on the rise of ALP. Anything to comment on this, sir, on the pattern of
Then
and
absolutely fine. In congestive hepatomegaly, you have both AST, ALT elevation as well as some amount of ALP, as you said rightly, Dr. Ramesh, because there is some component of swelling of the hepatocytes which actually results in canalicular obstruction. So there is some mild elevation. So it is not a typically obstructive elevation of LP, that there is no ALT elevation and only ALP elevation. So all the
yes,
factors may be rising a little. And yes, but bilirubin rise, as Dr. Ramesh has also pointed out, bilirubin rise is not as much because there is no defect in bilirubin metabolism in these patients. So you have congestive hepatomegaly. So because of the swelling of the hepatocytes, you have a slight elevation of STLT, maybe up to 200, 230, 250, something of those sorts.
yes, sir. Absolutely right, sir. The next question, which is over here, is that the role of steroids in alcoholic hepatitis. They are asking for our experience. See again, role of steroids and pentoxifylline. So these are the two only available modalities which have been there for the last 20 to 25 years. When I was also doing post graduation, say maybe 20 years back. So again, as a young postgraduate, we always had this enthusiasm. So can our intervention in hepatitis will lead to, with these two drugs or any of these two drugs can lead to reversal of or some improvement? So the experience is mixed. I will not definitely say that giving this will improve, but as per recommendation, if you find that the patient hasn't gone into cirrhosis and it is by the scoring that you find it that it justifies in giving, so then you may give. I will not go totally against it. My if Shubha Lakshmi is there, probably she may be better able to answer over this, or Dr. Anupam sir may also share his experience.
Well, yes, Dr. Ramesh, you are right. The recommendations are very clear when to use pentoxifylline and when to use steroids. And you should use, there is definite advantage. But the thing is, most of the patients that come to us, they are in such a poor shape, and at times they have secondary infections as well as SBP, that your starting of steroids is delayed, or even when you start, they at times once they go home they don't come back or they keep on drinking alcohol. So the prognosis remains poor, and in fact when the distributant function is very high, most of these patients also have coagulopathy, wherein these patients are bleeding and they are actually very sick. So it becomes a very big problem, and the prognosis remains poor for them. That is what.
Yes, sir. True, sir. Another question is that in upper GI bleed, any role of FFP? See, as per my knowledge for FFP is there that if at all there is any bleeding with deranged PTINR, so then we give FFP. Reason for upper GI bleed, if it is because of coagulopathy, so then definitely FFP will have a role. If it is not because of coagulopathy, then FFP will not have a role. So if we are talking of upper GI bleeds in a patient of, say, chronic liver disease, where you generally have INRs more than 2 or 3, then the only two modalities which we have, or three modalities, is vitamin K or FFP or some octreotide. So if that is the reason, so we must give. There is no reason that we should not. Any difference of opinion on this, sir?
Not fine, absolutely fine, Dr. Ramesh.
Sir. So another question which is there is the role of antifibrotic drugs such as nintedanib in liver fibrosis or cirrhosis. Uh, I don't think. it has been recommended, yes, yet in cirrhosis. Pulmonary trials have been there, but if I don't think so. But if there is a difference of opinion, people can put in chat. We can always go back and revise over this.
No, there are no.
Yeah. So I think sir is also Dr.
I
Anupam
don't
sir.
think there are
Yeah.
any trials.
Yes, sir. So why aren't enteric fever and tropical fever differentials of the first case scenario? I truly agree. I don't say that these are not the differentials. You are very right in putting these other differentials. It was just to give one of the, it is not just this was the question and this is the answer. It can have many differentials. Anyone who is having fever with jaundice, with tender hepatomegaly, can any of the tropical fevers or hepatomegaly or the hepatomegaly, any of the infections as one of the causes of the first clinical scenario. So very well, your this differentials are taken in patient with
About
refractory.
tentative, Dr. Ramesh, I just want to add that it causes elevations in aminotransferases. So actually, it is contraindicated in liver disease.
That is again a word of wisdom from Ratanipam sir. So we should not use these drugs in liver disease. In patients with refractory ascites, NSRCA along with hepatic encephalopathy, albumin should be given. We give. It is recommended. Refractory ascites again has very limited treatment options, so it may help. It can be given. Common drugs to be avoided in acute and chronic liver disease. So this is a huge list. I don't think so. I should answer over here. Anyone can Google over it and can see over it. But of course, NSAIDs and chemo drugs. So there are many drugs. Pentoxifylline in CLD again,
One should be
not
very
in C.
cautious with any drug in liver disease because most of the
Yeah.
drugs are actually metabolized in the liver.
Yes. So that is a very important question, rather, and that's what sir is saying. Patients of chronic liver disease, they can have a good number of years to live. Uh, it is only the doctor or the physician, if we guide their management properly, whenever they are admitted or when they come to the OPD. So just tailoring their medication, someone will be on antidiabetic drug, someone will be on antihypertensive drug, someone you will be giving antibiotic or any drug. So if you
The
take
pentoxifylline and
yeah.
steroids are basically. Sorry, Dr. Ramesh, yes, please continue.
Yeah, I just completed, sir, the previous question that what we were discussing about the drugs.
No, I was
I'm
just saying that pentoxifylline and steroids, as we already discussed, Dr. Ramesh was also saying, they are primarily
yeah,
for alcoholic hepatitis and not for CLD. But the
yeah,
patients that come to us most of the times come very late in the stage of liver disease. So they have actually irreversible liver disease and they do not present to us with alcoholic hepatitis. That is the biggest problem.
yes, sir. So I think most of the questions are done, sir, in this.
There is one,
Uh,
this can we give albumin to patients of CLD? Yes, this has already been discussed. Yes,
yeah,
vitamin K we give 10 milligram per day for 3 days, sir. Yes, that is right. Yes, I think most of the questions are done. There was a
yeah, yeah. So I'm very happy, sir, that if people
long
are
list of
putting
questions
on.
because this is a very
Yeah, very good, very good. I'm very happy, sir. That at least people are asking questions. That means they haven't slept. Sir, either my network or your network is not very clear. I'm not able to hear, sir.
no, that is okay. I just said that you had to face a long list of questions because the liver disease is so common and as this
Yes,
ascites, alcoholic
yes,
liver disease patients, they come to each hospital. So you had
yes,
to
sir,
face
yes.
a lot of questions, unlike most of us. Anyways, thank you so much, and it has been a
Yeah,
wonderful session. If there are still any questions, you can just drop in a message in the chat box. We will take them later on also. I'll thank you, Dr. Ramesh, once again for a splendid session, and thank you everybody for joining in. Thank you so much.
thank you, sir. Thank you,
Dr.
participants. Thank
Sanjay
you,
is
sir.
here. Dr. Sanjay, thank you so much on behalf of the ICP. So we call it a day. Thank you. Next week we are not meeting. We will meet after a fortnight because Dr. Kamlesh is free Saturday next week because I will safe, holy. Thank you and best wishes.
Thank you, sir. Thank you.